Hello and welcome to the Laboratory Matters, where we discuss all that matters in a laboratory. So we move on to Module 3 in our course entitled Decoding Diabetes Mellitus in the Laboratory. In Module 1, we learned about the various samples that are received in the lab to diagnose diabetes mellitus, the various tests that can be done, and the method of sample collection, transportation, storage, the primary tests that are done, most common being measurement of glucose in serum, plasma, CSF, urine, and of course, glycated hemoglobin. In this module, we shall continue with the various tests that are used to diagnose and monitor diabetes mellitus. We come to one of the most important tests, which is urine albumin. Now, we all know that diabetes mellitus is all-consuming. It can affect any organ, and therefore it can give rise to any kind of damage in any organ, small or big. And one of the most commonly affected organs is the kidney. And how do I diagnose renal damage? We all know that the kidney needs to be damaged to a reasonably large extent before you actually start to see a lot of biochemical changes. So in any diabetic who is being monitored, who's being treated, apart from measuring blood sugars, apart from measuring the glycated hemoglobin, we also need to look at his urine. And in the urine, it is urine glucose, urine ketones, and of course urine albumin. So this is an important method of detecting renal damage or diabetic nephropathy. What are the various methods? One is a semi-quantitative, just like we do glucose, semi-quantitative dipstick assay. In this we see for protein, and protein is usually albumin because albumin is the smallest particle that can be filtered through the glomerular filtration membrane. Then you can also do a quantitative assay of albumin in the urine. So it follows the same course like glucose. Now, in the normal person, the normal is less than 20 micrograms per minute or less than 30 milligrams per 24 hours. Please note the units. And if you're looking at an albumin creatinine ratio, it's less than 30 micrograms per milligram urine creatinine. Now, when you have high albuminuria, which was earlier called microalbuminuria, which means that before you can actually with your dipstick detect protein, it is something that comes before you detect protein using the normal methods. So you had a separate kit and there was a method to detect these microproteins or microalbuminuria. So high albuminuria was 20 to 200 micrograms per minute or 30 to 300 milligrams per 24 hours. 30 to 300 was the ACR also. And then there was this very high albuminuria, which was greater than 200 micrograms per minute, greater than 300 milligrams in 24 hours, and greater than 300 being the ACR. So this is how today we report urine albumin. We don't call it microalbumin, we call it urine albumin or microprotein. What are the semi-quantitative assays? This is again a screening test. So you use your dipstick in which you use it for your normal urine routine examination, where you grade the albumin positive from 1 plus to 4 plus. And if there is no protein in the urine, or if there is no albumin that you can measure in the urine, it does not mean that there is no renal involvement secondary to diabetes. Now, if you drink a lot of water and there is a dilute urine, even that will give you a false negative report. Now, supposing you refrigerate the urine samples and then you want to do it as a batch or you want to process it later, then you should allow the refrigerated urine samples to reach at least 10 degrees centigrade before you analyze to prevent any coagulation due to cold or some kind of a false negative report. So you can either use a dipstick which has 8 parameter, 10 parameter, 11 parameter, or you can use the ones which have only protein or protein and sugar. So this is how we do a semi-quantitative or a screening test or a qualitative test, or whatever you want to call it. The quantitative assays, you use immunochemistry with antibodies to albumin. So you use immunoturbidimetry, RIA or immunodiffusion. So using any one of these principles, we will measure urine, albumin, and that you can do using your routine chemistry analyzers also. Now, we have to know what is albumin creatinine ratio. This was earlier called protein creatinine ratio. Now we are very specific and we call it albumin creatinine ratio. Now, because there is a variation in urine flow and you're not able to correctly measure the amount of protein in the urine at that given juncture, what we're doing is we're simultaneously measuring urine albumin and urine creatinine and expressing it as a ratio which is called albumin creatinine ratio. Now, this is a very practical test. It will give you a correct idea rather than measuring just albumin separately. Albumin may be high at some point or it may be low at some point. So this can be measured in a random sample. Anytime the patient comes in to see you, you can ask for the test, though a morning voided sample is preferred. That's the best sample to measure the ACR. Now, all the following urine samples are acceptable. A 24-hour collection where we will give you a 24-hour output of albumin or creatinine. Overnight, 8 to 12 hours timed collection after this will be an overnight timed collection, or a 1 to 2 hour timed collection in a laboratory or clinic. So after 1 or 2 hours, you please come and give the urine. But the best sample is a first voided morning sample. Now, at least 3 samples collected on different days should be assayed, and only then you should say that there is secretion of albumin in the urine, or this patient may have has evidence of renal damage. So you should not just do one assay or one random assay, and you should not label the patient as having renal diabetic nephropathy. So you collect the first voided sample and do it 3 times, okay, on 3 different occasions, and it should be giving you the same high value. Then you can say that there is evidence of renal damage. If you store samples at 4 degrees centigrade, if you store the urine at 4 degrees centigrade, immediately after collection, this analytes will be stable for 1 week. So this is important on how you collect the urine and when do you test it, how many samples you test, and what is the stability of the analyte. Now, what are the pre-analytical factors for urine? The urine collection should be standardized. In any laboratory, we have to standardize all the methodologies of collection so that that particular pre-analytical variable is ruled out. So samples should not be collected immediately after exercise or exertion, because you know that post physiologically after exercise or exertion there is an excretion of urine, excretion of protein in the urine. So this could falsely elevate your protein in the urine. With or associated urinary tract infection will give you an increased protein because of the presence of leukocytes and blood cells. Diuresis. Immediately after surgery, after or during an acute illness, after an acute fluid load. So these are important pre-analytical factors, and you should not collect urine when all these factors are active. So you have to take it from a normal person, or rather a person who's not exercised, who is not stressed, who does not have urinary tract infection, who doesn't have fever, who does not have an acute illness, or who has not drunk so much of water, or has not taken plenty of diuretics and passed a lot of urine. So, all these factors play an important role in giving you a proper result. So these have to be borne in mind before you tell the patient to collect a first morning voided sample. Now that is about urine. The next test, which is done but not very commonly, is insulin. Now, what is insulin? Insulin is a hormone that regulates the glucose. It's produced by the beta cells of the islets of Langerhans of the pancreas. Now, it's an anabolic hormone. It stimulates the uptake of glucose into fat and muscle. That means it improves the utilization of glucose by the different end organs. It promotes the conversion of glucose to glycogen or fat or for storage. It inhibits the glucose production by the liver. It stimulates protein synthesis and inhibits protein breakdown. So protein breakdown can also cause an increase in the glucose. So if this insulin is not there, then, or if there is a resistance to the action of insulin, then the uptake of glucose, either for storage or for utilization, will not happen, and therefore the glucose levels in the body will increase. So that is the basic function of insulin as being an anabolic hormone. Now, how do we assay insulin in the laboratory? We do an immunoassay, but the most specific method or a sensitive method is IDMS, or isotope dilution mass spectrometry. It's not available in every laboratory. Many laboratories use immunoassay, and you can use ELISA, you can use the other CLIA, and so on and so forth. What is the use of insulin? It is used to identify causes of hypoglycemia. So if a patient presents to you with hypoglycemia, doing an insulin assay can tell us why the patient went into hypoglycemia. So what are the causes of increased insulin levels? Obesity, steroid administration, acromegaly, Cushing syndrome, and early stages of type 2 diabetes. All this will lead to an increase in the insulin levels. Decreased insulin level post-pancreatectomy, chronic pancreatitis, autoimmune destruction, and type 1 diabetes. So now we see the difference between type 1 and type 2. In type 1, there is a lack of production of insulin by the beta cells of the pancreas. So there is a decreased insulin level. In type 2 diabetes mellitus, there can be normal or increased levels of insulin, but there is a peripheral resistance to the action of insulin, which prevents the glucose from being utilized and therefore causing hyperglycemia. So you can do the insulin assay either fasting or in a postprandial stage. Both of them will give you this kind of a picture. Fasting insulin is less than 25 milli-international units per liter, and postprandial insulin is between 16 to 166 milli-international units per liter. So the insulin test will be ordered only in those cases where we are not able to correctly come to a diagnosis of hypoglycemia or hyperglycemia. One. Two, in cases where you're suspecting type 1 diabetes, then we establish a baseline value of insulin to know whether the insulin is dropping or insulin is increasing, whether there are any beta cells at all, whether this patient will need a pancreas transplantation, and so on. So that is like a base level test. You don't have to do it every month or every 3 months or every year. Once you can do and establish your baseline level of insulin. Now we move on to something that is similar to insulin, which is called C-peptide. Now, the storage form of insulin is proinsulin. Okay. and it is stored in the secretory granules of the Golgi complex of the beta cells. Now, proteolytic cleavage to insulin and connecting peptide occurs. So this proinsulin gets cleaved, gets split into insulin and the connecting peptide, which is called C-peptide. So the full form of C-peptide is a connecting peptide. This C-peptide has actually no biological activity. It does not go and do anything, but it is needed to ensure the correct structure of insulin. So if there is proinsulin which is being stored and it has to be cleaved to insulin, this connecting peptide needs to be removed. So that is why we measure the connecting peptide to ensure it's to know that the structure of insulin that is there in your body is the right kind of insulin. Now, increased levels of insulin, increased levels of C-peptide are seen in insulinomas and insulin resistance, as in obesity, Cushing syndrome, chronic renal disease. In all these cases, there is insulin resistance and increased C-peptide. Decreased levels are seen with type 1 diabetes, exogenous insulin injection. So this is a surrogate marker for exogenous insulin injections. So the patient's insulin levels will be high, but C-peptide will be low. Then you know that it is not normally or naturally secreting insulin, but insulin that has been administered from outside. This could be useful even in forensic conditions. Insulin dependent hypoglycemia. Now, in short, if I have to tell you what is C-peptide, it is a measure of beta cell function. So if the beta cell is functioning properly and it is secreting insulin, insulin which will be stored in its precursor forms, this C-peptide is cleaved from it and therefore it becomes a surrogate marker of the measure of beta cell function. Now you can measure C-peptide even in the urine, and urinary C-peptide is used for continuous monitoring of the beta cell function. So if you measure the amount of C-peptide that is being secreted in the urine, you'll know whether the beta cells are functioning properly or not. So we have these two tests which are not done very commonly, but usually in cases where you suspect type 1 diabetes, to differentiate it from type 2 diabetes, we do insulin and C-peptide and establish a baseline level in these patients. So we do immunoassay to measure C-peptides. The fasting level of C-peptide is 0.78 to 1.89 nanogram per ml. The postprandial levels are 1 to 3 nanograms per ml, and urinary C-peptide is 48 to 100 micrograms per liter. So these are the normal biological reference ranges that we have for C-peptide. And like I said earlier, they're not very commonly done tests in all diabetics. Moving on, we also have certain tests which are immunological markers. Now, if you recollect, when we differentiated type 1 diabetes from type 2 diabetes, said type 1 diabetes was an autoimmune disorder. So when you have an autoimmune disorder, you can measure antibodies to ensure that you're diagnosing diabetes mellitus properly. And what are the common antibodies that we can measure to establish a diagnosis of diabetes mellitus type 1? One is called the islet cell antibodies, pancreatic islet cell antibodies, insulin autoantibodies, IAA, GAD antibodies or glutamic acid decarboxylase antibody, IA2 or protein tyrosine phosphatase antibody, or ZNT8 or zinc transporter 8 antibody. So of these five, the most commonly done is GAD antibody. Again, when we want to differentiate between type 1 and type 2, all these are positive in type 1 and are not seen with type 2 diabetes mellitus. So the commonly done is GAD antibody. You also sometimes do ICA and IIA. So these are the immunological markers. markers, and positivity of these immunological markers would indicate a diagnosis of diabetes mellitus. So to sum up, apart from doing glucose and glycated hemoglobin, we also do urine albumin, urine creatinine, urine ketones, albumin creatinine ratio. All these are very useful tests, especially in monitoring and also to diagnose early onset of diabetic nephropathy. Then we have insulin and C-peptide, which are useful in the diagnosis, especially of diabetes mellitus type 1, where their base values are very useful to know. To further strengthen the diagnosis of diabetes mellitus type 1, we have immunological markers because diabetes mellitus type 1 is an autoimmune disorder, and the most commonly used immunological marker is GAD antibody. So we've now covered the specific tests that are useful for the diagnosis of diabetes mellitus, a few of them which serve as baseline tests, a few of them which are useful in monitoring, few of them which are useful to predict the end organ damage or the damage to other major organs. So I think you've got a clearer idea about what are the tests, how we do them, how we collect the sample, how we can test them, what is the principle of the test, what are the kind of pre-analytical variables that are important, and what can be used to differentiate type 1 and type 2 diabetes mellitus, and how we diagnose gestational diabetes mellitus. With this, we come to the end of module 3. And before we move on to module 4, where we learn how to monitor diabetes mellitus, we wish you happy learning. Thank you for your patient hearing and wish you a happy learning from the laboratory matters.